I think the audience listening to this talk sometimes may be overwhelmed by the multitude of data and data points and the ambiguity of the interpretation of this data, but let me clarify and make this very simple. Starting from our extreme right of the panel, I would ask Zayomi if she could outline her top 3 endovascular SFA devices she uses. Don't be shy to say PTA because that is not a taboo. So top 3 devices.
I think I tend to use Zilvers. I tend to use self-expanding bare metal. I don't, angioplasty is first and foremost. If I can get a good result from that, I leave that and go forward.
So I'm not going to cut off, but I just want to keep it short. So angioplasty and stenting with DES and BMS. I think next panelist, please be short, be precise.
For me, it would be angioplasty, non-drug coated, then DCB, and then probably a non-drug coated stent.
Okay.
Angioplasty, scoring balloon, drug-eluting balloon.
Angioplasty, scoring balloon, and then drug-coated balloon.
That's, generally speaking, drug-eluting balloon and stent only for rescue, atherectomy only for severely calcified disease.
No, the top 3. So I think top 3, you said PTA, scoring balloon, and DCB. There's your majority of cases.
Yes.
Is that right? Majority of cases, okay? Next, our...
I mean, it probably still is
Arthur?
DES, DCB, and atherectomy, maybe directional up there.
So atherectomy followed by stenting.
Atherectomy followed by balloon and stenting. If needed.
Balloon and stenting.
Yeah.
For me, it's DCB is a primary, followed by DES when I know I'm stenting, and Supera if I need a scaffold.
Alec?
PTA, bare metal stents, and stent grafts, self-expanding stent grafts.
Fantastic. Mehdi?
DCB, DES, Supera.
DCB, DES, Supera. Okay.
Balloon angioplasty, Supera, and in high-risk patients, CLI, DCB, or DES.
Balloon angioplasty, PTA, DCB, and if required, focal DES. Anyone in the audience, I know there are many people who do this procedure, so I really want you to, if you don't want to go up to the microphone, just stand up. Dr. Ansel, I can't call on you, I don't have the stature to do that, but if you would be kind enough to say, what are your top 3 things you do in your lab every day? Use the microphone. And I want to also apologize, I misintroduced my colleague, Dr. Peter Sukas. I called him the surgeon, actually he's an interventional cardiologist, that even more highlights the selections of the cases he made. I'm so sorry, Peter.
Yeah.
Go ahead, Dr. Ansel.
Drug-coated balloon, then I use Supera for calcified lesions, atherectomy if I need to develop that for some reason.
So those are the top 3. Dr. Bianchi, I hope this highlights some of the issues. There are questions here. Are there any microphones for anyone? Scott, thank you for doing that.
Do you guys use Lotus
No. Okay, we are going to go back. Okay, there's a question here, please. Take the microphone. Scott, thank you very, very much for doing so.
As a surgeon, I use atherectomy primarily, even on shorter lesions. I have a lot of durability with that I've seen. I can't document that with my studies, but it seems to be very durable for me. I use directional atherectomy primarily because it seems to be more effective with eccentric lesions. I use drug-coated balloon following atherectomy in almost every case.
Peter, last person, can you highlight your top 3 devices you use? Microphone behind you, please.
Yeah, it certainly has changed dramatically in the last couple of years with the introduction of lithotripsy. So a lot of our patients have calcified lesions, so I would probably say lithotripsy, DCB, and Supera.
Thank you very much. Christian?
Do you want to continue?
So I want to also get back to the issue of technique. So I think one thing you might all agree, I hope so, that the DCB trials have actually personally made me better angioplasty person. I do not go up and down with the balloon. So let's speak a little bit about what can we do about the techniques of treating calcified lesions. So we heard a lot of devices being shown with atherectomy. I will start with my co-moderator. Highlight your #1 atherectomy tool and why. Leave the dollar sign out.
Actually, I have little to no experience. I work in a VA system in which without the data, we rarely use atherectomy.
Fair answer. Mehdi, #1 atherectomy device and one reason why.
Yeah, I don't have a #1 because it depends on the lesion, to be honest with you. So if I have an instant, occlusion, I'm not gonna use I have a different #1 than if I have severe calcification. So for severe calcification, I think for me probably is orbital atherectomy. For in-stent is laser. I would say those two, and then directional atherectomy if I'm in the common femoral popliteal or areas where I really want to do debulking. So those would be my three.
Great answer. Alec?
We no longer use atherectomy routinely. We've used it in the past. We've had complications in our hands. It does not add much.
I agree with Mehdi, but I mean, if you just take your de novo SFA lesion, probably directional for me.
Directional.
Yeah, I mean, as a cardiologist, the two big things that make my life hard are calcium and clot. So my most common is CSI. I'll do some hawk above the knee, but CSI mostly.
CSI number one.
Calcified lesion, orbital atherectomy, occlusion, and in-stent laser.
Perfect answer. Tony?
For me, it's CSI, and if it's in-stent, laser.
CSI. And Ziomi?
I've honestly not used atherectomy at all.
Very, very clear. The surgeons do not use atherectomy. They use the knife because that is a great atherectomy tool. So,
Start
yes.
with me?
Yes.
No,
No.
I don't.
Tony?
I go after a failed antegrade approach.
You'll go after a failed antegrade approach.
I use
Pinter?
retrograde approach quite routinely for claudican.
For claudican, routinely. Art?
Yeah, I use it. Depends on the runoff status and how good the vessels are, but I'll use it after, again, discussion with the patient about, getting across versus risk.
Same, but rarely.
I didn't get what?
Yes, I use a retrograde approach for claudication, but fairly rarely.
Rarely. Alec?
Rarely.
Very rarely. Mehdi?
After failed antegrade approach.
After fail antegrade approach.
I think I would say rarely, and that's the position. Any questions from the audience? I think, yes, please take the microphone, please. Go ahead, please.
Sorry,
Can you introduce yourself and where you're from?
I'm Juan Pablo Zimmerman from Buenos Aires, Argentina.
Welcome.
If in a case, in eventual case, you have the SFA occluded and it's a claudican patient, and you have the profunda with a severe lesion, very severe lesion, and the profunda brings very good collateral flows to the SFA. Do you think it's enough to treat the profunda, or you must treat the SFA?
Go ahead.
This is a great question. I think if the profunda is large and has a severe stenosis, there's a high likelihood that treating the profunda alone might fix the claudication.
Great question. Another question. Please use the microphone and introduce yourself, please. Great question. We have placed the microphones especially behind the camera so that there's no disturbance, so please.
Yeah, Frege Gobo from Seattle. So I have two questions. The first question, I notice in my practice, in the femoral popliteal segment, there's two types of calcification, intimal and media calcification. I wonder what the panel recommend for the media calcification, because I don't see better lumen gain with using the different combination you guys mentioned today. The second question is, what is the best stent if you need to land exactly at the ostium and avoid going across the profunda or to the common femoral artery? Thank you.
Great question. Anyone? Mehdi, you want to take this first?
Sure. I mean, I think from a standpoint of calcification, I think that's one of the challenges, because it's hard, at least for me, to tell sometimes whether it's intima or media. I think it's true, and it's sometimes, the calcium is so far from the lumen that is interesting. So for me personally, it doesn't really change my management in regards to treating the patient, whether it's intimal or medial. I look for the balloon, the pre-dilatation. If that doesn't respond, then I make a decision, or I make a decision a priori whether I need to use atherectomy because of heavy calcification to be able to expand. So that's usually the case. Usually the intima is the one that gives you the hard time. The media, you can push it to the side. In regards to what stent to use to get the better positioning at the ostium of SFA, I think that most of the stents are the same. The only one I would not recommend is Supera, because I think it would be very difficult if you're trying to get it flush at the ostium of the SFA, you probably get into trouble. The rest of the stents, you just obviously have to be careful, but they are about the same in my experience.
Christian, you have a point for this?
No, nothing to add.
I think this has been a great session, great questions, fantastic discussion, and a lot of controversy. I tried to trick you guys into more controversy, but you guys are pro-panelists now at CVI and at other meetings. So thank you all for being here, for attending this great session. I encourage you to keep your questions alive while the panelists are here and harass them over lunch. I once again thank you all for coming from wide and far. I hope this has been a fruitful meeting for you all. It has certainly been for us at CVI 2019. Thank you, and take for lunch.